Hi everybody, welcome to Dr. Mannys YouTube Learnshops. Today we're going to review evidence-based practice, looking at some of the basic principles. Right, the session objectives are to define what evidence-based practice is, look at and discuss some of the principles of evidence-based practice, review levels of evidence for practice and put it in the context of nursing and relevance of evidence-based practice in our profession. So this is something that you should do. So consider the following questions. Have you ever wondered if there's a better way of assessing or caring for a patient? Have you ever had a conversation with a colleague, a friend, about a technique and wanted to know if it would work? Have you ever heard of a news story and questioned if the information was correct or whether it would apply to your nursing practice? Have you ever been asked a question about a management or a treatment or a therapy or condition that you haven't heard of before? Consider a hypothetical situation, for example. You visit the family doctor that you've been going to for the last 20 years. After gaining considerable weight, let's say during the COVID-19 pandemic, MCO, the doctor advises you to try Diet X. However, it's very expensive and requires a radical change in your lifestyle. But, the prospect of having a slim and healthy body motivates you to proceed. After a few weeks on this diet, you've actually gained 3 kilograms and you're starting to have symptoms or medical side effects which require you to go to a doctor. Your nursing colleagues or friends search the internet and tell you that the current scientific studies reveal that this Diet X is actually ineffective and is associated with many side effects. When you go back to your family doctor and you consult and explain these findings, he replies, "Why should I bother with scientific studies? I've got 30 years experience and this diet that I put you on was actually developed by a famous American nutritionist and dietitian whose book sold more than 1 million copies." Now, does that sound like malpractice? It probably does, but unfortunately in healthcare practices, disregarding best evidence based on best practice, and often practitioners rely on personal experience. This is a common phenomenon. Have a look. Because we've always done it that way. That's the mentality. And I've struck it many times in my career. So, what is evidence-based medicine? Well, evidence-based medicine is the conscientious, explicit and judicious use of current best evidence in making decisions about the care of individual patients. The practice of evidence-based medicine means integrating individual clinical expertise with the best available external clinical evidence from systematic research. This is a concept that's been widely embraced in healthcare areas, and the term evidence-based practice has evolved from the term evidence-based medicine. Evidence-based practice requires that decisions about healthcare are based on the best available, current, valid and relevant evidence. And decisions related to this should be made by those receiving care, informed by tacit and explicit knowledge of those providing the care within the context of the available resources. That's evidence-based practice. Let's review a brief history of evidence-based practice. The term evidence-based medicine was introduced by Guyot in 1992 to shift the emphasis in clinical decision-making from intuition, unsystematic clinical experience, and pathophysiological rationale to a more scientific, clinical relevant research base. The concept was embraced, but it was also criticised. And the main criticism was that evidence-based medicine or practice relies too heavily on research. Sackett explained evidence-based clinical decision-making as a combination of research, which is evidence, but also clinical expertise taking into account the patient's or client's preferences. It was Satterfield in 2009 who developed a transdisciplinary model for evidence-based practice. And this model depicts the core 3 components, which are best available research as evidence, clinical expertise, and again, the patient's preferences. What are the benefits of evidence-based practice? Well, the benefits involve clinical decision-making using a systematic approach, and nurses, like other healthcare professions, have a clinical responsibility to help their patients to be as healthy as possible. Evidence-based practice offers a framework for deciding which course of clinical action may be the most appropriate for any given patient. And it's evidence-based practice knowledge and skills that allow you, us, to answer your questions for your patient. And as a consequence of that, evidence-based practice should improve your practice and result in better outcomes for your patient. Evidence-based practice, it's the meticulous use of current best evidence in making decisions about patient or client care. It's the collection, evaluation and integration of valid current research combined with clinical expertise and an understanding of the patient and family values and preferences which inform your clinical decisions. All concepts that we've discussed previously in science and science in nursing. This is the evidence-based practice triad. And this involves, as we said, the incorporation of 3 components to improve outcomes and the quality of your patient's life. External evidence includes systematic reviews, randomized controlled trials, best practice and clinical practice guidelines that support a change in clinical practice. And as I said, evidence-based practice is a conscientious, problem-solving approach to clinical practice that incorporates the best evidence from well-designed studies, the patient's values and preferences, and a clinician's expertise in making decisions about patient care. Okay, your time again. Consider the following. We said, evidence-based practice, this involves clinical decision-making using best evidence. It requires clinical expertise and patient preferences within the context of your work environment, the healthcare environment, whether it's a clinic or whether it's a hospital. It offers a framework for appropriate clinical actions, and knowledge and skills provide answers for questions regarding the patient and patient issues. And as a consequence of this, it should improve practice and result in better outcomes for the patient. Well, what then signifies evidence? I mean, when we say evidence, we basically mean information. And the best way to think about it is in legal terms in a court of law. And that's the same for nursing practice decisions. So evidence may come from scientific research, as we've indicated previously, suggesting generally applicable facts about the world, people and organisational practices. And it can be based on either qualitative or quantitative information, therefore being descriptive or statistical with numbers. In a court of law, evidence, for example, is presented in a variety of forms, from either eyewitness testimonies and witness statements to forensic evidence and security camera images. All this evidence helps the judge or jury decide whether a person is innocent or guilty. And as I said, it's the same for nurses' practice decisions. Regardless of its source, all evidence may be included if it's judged to be trustworthy or relevant. Consider sources of evidence. According to the principles of evidence-based practice, evidence comes from 4 sources, which should be considered. Scientific evidence, and this is findings from published scientific research. Organisational evidence, which is data, facts and figures gathered from the organisation. Experiential evidence is your professional experience and the judgment that you have as a practitioner. And then you've got stakeholder evidence, which concerns the values of people who may be affected by the decision, your patient, employees even. Okay, the first source of evidence is scientific evidence. And this is typically scientific research published in academic journals. And it's important to remember that new research is always being produced, and this often changes our comprehension and our practices. However, in order to include up-to-date scientific evidence, you've got to know how to search for it and judge whether it's trustworthy or relevant. Then you've got organisational evidence, and this is the second source. And the second source of evidence is the healthcare organisation itself. And this information or evidence can come from patients or employees. It can be hard numbers or it can be soft elements. And it's essential in identifying problems that require attention and determine causes and solutions that are needed to implement these solutions. Then you've got experience. Evidence that comes from experience, experiential, and this is the third source. And this is the experience and judgment of healthcare professionals like doctors, nurses, pharmacists, physiotherapists, and so on. And it's this type of evidence that's sometimes referred to as unspoken or tacit knowledge, which we've discussed previously. And their knowledge can be vital, your knowledge can be vital for determining whether data is trustworthy for a particular situation. Then you've got the final source of evidence. You've got the fourth source, which is the stakeholder, the values and concerns. And internal stakeholders could be you as the employee, or external stakeholders can be outside the organisation, which includes patients, the public. And it's evidence from stakeholders that provide a frame of reference for what's important, especially for ethical reasoning. What's the rationale for evidence-based practice, which we'll go over and over and over again? Why is evidence-based practice important? Well, it's important because it aims to provide the most effective care that's available with the aim of improving patient outcomes. And patients expect to receive the most effective care based on best available evidence. So the use of evidence-based practice ensures that your clinical practices are based on sound evidence, and patients will benefit as a result. So when we look at the 5 A's in evidence-based practice, we have, first of all, the first A is to assess your patient. The second A is to ask clinical questions. The third A is to acquire the best evidence. The fourth A is to appraise the evidence. And the fifth A is to apply that evidence to patient care. So let's look at it in a little bit more detail. So the rationale is a 5-step process. Ask, which formulates an answerable clinical question, which you have. Otherwise you wouldn't be asking. You access or you search for the best evidence. You appraise the evidence for its trustworthiness, validity, reliability, usefulness, whatever terminology that you want to employ. And then you apply, which means you integrate the results within your clinical expertise, your patient's values, and the setting. And then you assess, which is to evaluate the effectiveness of the whole process. Evidence-based practice, as I said, is about making decisions through a conscientious, meticulous, explicit, and judicious use of best available evidence from multiple sources. And if we take it one step further, let's review it from a nursing perspective. This is just one of the evidence-based process steps, which extends from the previous one. So when we look at it, we still have a systematic approach: asking, acquiring, appraising, applying. However, we have auditing and then assessing. Asking, translating a practical issue or problem that you've identified into a question that can be answered. Acquiring means gathering the data. So you're searching and retrieving best evidence, current evidence. Evidence should be current, certainly within the last 5 years of the current year. Appraising, then critically evaluating the trustworthiness and relevance, validity, reliability of the evidence. Then applying it in your decision-making process. And then auditing and deciding whether it's weighty enough and can be used as evidence. Then assessing, evaluating the outcome to increase the likelihood of a favourable outcome. Well, why do we do that? Well, in some healthcare practices and decisions, they're not based on best available evidence, which you would have identified when I asked you those previous questions at the beginning of this session. And as a consequence of that, practitioners often prefer to make decisions that are solely rooted in their personal experience. Well, gee, look, I've done this for the last 30 years here now, and it's always worked before, but it's not based on any best practice or evidence. And as we indicated, or you probably identified, personal judgment is not a reliable source of evidence because it's susceptible to biases that may have negative effects on the quality or the decisions that you make, we make, healthcare practitioners make. Few practitioners have been trained in the skills requiring to critically evaluate the trustworthiness and relevance of information they use. That's a barrier. That's a potential barrier to evidence-based practice processes because people don't know how to do it, so they avoid it. Practitioners are often not aware of current scientific evidence available on key issues in their field of practice. And most practitioners who are pay little attention or no attention to scientific evidence. They place trust in low-quality evidence such as personal judgment, experience, best practices that they've done, that's the way we've always done it, and belief in their medical leaders. Nurses, I can give you numerous examples. Oh, he's the doctor, he should know. He's the doctor, he is more knowledgeable than I am. Nurses say that. And they say it in Malaysia. And they say it in Australia. And they say it in most countries. As we've indicated, an important aspect to now evidence-based practice is asking the right question. And this is where you translate the practical issue or problem that you've identified into an answerable question. It's important to make it simpler for you and make it structured and use a systematic approach. And that means using a tool. And I've chosen PICO to formulate elements of the question. And there are lots of other tools that can be employed, depends on what your question is. But PICO uses 4 components and it's a mnemonic. P-I-C-O. P means patient related, population related or problem related. And what are the most important characteristics of those 3 components? Or the intervention. What's the main intervention that you're going to be considering? Comparison. What are the alternative benchmark or gold standards that are being considered, if any? The outcome. What is the estimated likelihood of a clinical outcome that's attributable to a specific disease, condition or injury or problem? Let's explain PICO further. P, patient, problem, population. This describes the group of patients which could be similar to your own. So for example, you've got elderly patients with congestive heart failure. What intervention, I, are you considering? Does the treatment involve a diuretic, for example? Could be furosemide, spironolactone, bendrofluoroside, etc. So what's the comparative or the comparison intervention? What's the main alternative when you compare it to standard therapy alone? So for example, here the standard therapy could be fluid restriction. The patient is limited to 1,500 mils, 1,000 mils every day. And you add the intervention which could be a diuretic. So what's the outcome? Does it improve their clinical status? Does their breathing improve? Does it decrease their hospitalisation? Or how often they do go and see their physician? PICO. Patient, intervention, comparison, outcomes. Just one tool. Then there are other examples, just to reinforce the concept. P, for example, children with otitis media. The intervention is antibiotics. The comparison is no treatment, just give them paracetamol if they get a fever or they have pain. What's the outcome? What's their pain like after 2 days? And so on. PICO, an important tool to use when you're formulating your question. Again, why evidence-based practice? As I've indicated, some healthcare practices and decisions are not based on best available evidence. Instead, practitioners often prefer to make decisions rooted solely in their personal experiences, especially some of the physicians and nurses. Personal judgment, as I said, is not a reliable source of evidence, as it's susceptible to biases that have negative effects on the quality of decisions that are made for patients. So this is for you. This is for you to reflect on. Why do we focus on best available evidence? And this principle is apparent in everyday decision making, whether you're buying someone a birthday present or wondering where to go out for dinner, or even whether you should go out to dinner in relation to social distancing, the COVID-19 situation. However, in most cases, we actively seek out information from multiple sources. It could be our colleagues, our partner, our mother, our father, the experiences of friends or comments, for example, of a local food critic. And it's sometimes this information can be really, really poor or weak but it's hardly convincing at all. While at other times the information is really, really strong and no one doubts its correctness or trustworthiness or reliability or validity. So therefore, it's important to be able to go through and critically appraise to determine whether evidence is best, which is the most trustworthy evidence. Okay? Think about it. Why do we critically appraise evidence? All evidence should be critically appraised to assess trustworthiness and relevance. Is it best? Is it relevant to what you want to find out? And remember, evidence is never perfect, and it can be misleading in many different ways. So, critical appraisal and evaluation involves asking these questions. Where and how is the evidence gathered? Think back to your scientific philosophy, your epistemology, your ontology, your axiology. Is the best evidence available? Is there enough evidence to reach a conclusion? Is the evidence accurate and reliable? And for that, you've got to look. How was the study designed? This is your methodology. How was the data collected? Methodology. How is the outcome measured? Methodology. When you evaluate your information, think of it as evaluating your sources. Relevance, accuracy, author, purpose, currency. So how relevant is it to what you want to find out? How accurate is it? Is it fact, fiction, opinion? What are the references? Who's the author? Is it an expert in the area? What's the purpose? Is it to inform, to persuade, or to sell? And how current is it? As I've indicated previously, it should be current within the last 5 years of the current date, unless it's a classic or traditional or historical article to give support to what you're talking about. This could be Florence Nightingale, for example, 1900. So, evidence-based medicine or practice is inherently meant to tailor best evidence to the needs and preferences of a particular patient, and this is based on clinical judgment of the clinician. The clinician should be capable, the author. Evidence-based practice is also based on best available evidence, which requires evaluation of all the relevant evidence and grading of its quality, accuracy, currency, author. And ideally, evidence-based practice uses patient-orientated evidence, outcomes of importance to patients, such as morbidity, mortality, and quality of life, rather than disease-orientated evidence, which is physiological variables such as blood tests, results, when you're making these clinical decisions. So this is relevance. Does it suit the purpose of what you want to find out? So let's go back again. Consider the following situations. Healthcare practices and decisions that were based on personal experiences. Healthcare practices and decisions that were based on traditional time-honoured practices. Healthcare practices and decisions that were not based on best available evidence. Based on personal experience. Well, gee, I mean, it's always worked when I've done it in the past. When I did this, this always happened. No, I'm not sure whether it's evidence-based, but from my personal experience, it seems to work. Based on traditional or time-honoured practices, well, that's the way we've always done it. When I started here 50 years ago, this is how we did it and this is how we continue to do it. not based on best available evidence, well, I'm not sure, I'm not aware that it actually exists in the literature. And I'm not sure whether it's based on evidence-based practice. When we look at the levels of evidence, there's the evidence-based medicine pyramid. And this is simply a diagram that was created to help healthcare practitioners, doctors in particular, to understand how to weigh different levels of evidence in order to make health-related decisions. However, it helps us as healthcare practitioners to put the results of each study design into perspective based on the relative strengths and weaknesses of each design. So, higher levels of evidence, when you look at the evidence-based medicine pyramid, has got 7 levels. And you should always seek the highest level of evidence available if possible. But you also have to remember that the evidence at the top might not exist for your clinical question. So you're going to have to be compliant and think of other levels. You may not always be able to get, for example, a systematic review. Then you've got lower levels of evidence. And if, for example, you can't find what you want to answer your question in the higher levels of evidence, you're going to have to move down. And you move down until you find the strongest evidence for your question that addresses your clinical question. So when understanding the levels of evidence, you've got to put it into the context. The top of the pyramid represents the strongest evidence, which is filtered. It's been really critically reviewed. And CAT topics, critically appraised topics, include systematic reviews, meta-analysis, and critical appraisals. In short, a CAT is a short summary of the best available evidence created to answer a specific clinical question. And this is a form of level 1. And level 1 evidence is evidence from systematic reviews or a meta-analysis of all the relevant randomized controlled trials or evidence-based clinical practice guidelines based on systematic reviews of randomized controlled trials, or 3 or more randomized controlled trials of good quality that have got similar results. So, first of all, a systematic review focuses on a clinical topic that answers a specific question. It's a thorough literature search which has been conducted to identify all the studies using sound methodology. The studies are evaluated and the results are summarised according to pre-selected criteria. There are no quantitative statistics or analysis done in a systematic review. Then you've got meta-analysis. A lot of analysis, basically. A meta-analysis carefully examines a number of credible studies on a topic and combines the results using quantitative statistics. And it's a higher quality of systematic review. And therefore, that's why it's at the top of the pyramid. And it uses the databases to limit the search to systematic review and meta-analysis. When we will understand further, at the base of the pyramid, this is unfiltered. And this includes randomized controlled trials, cohort studies, case reports, and the opinions of experts. And these are individual reports and studies, and they can also be known as primary literature. A randomized controlled trial is carefully planned. It studies the effect of therapy on patients, and these reduce the potential for bias. And it allows the comparison between interventional groups and control groups. It's evidence-based on at least one well-designed randomised controlled trial. It's level 2. Then you've got cohort studies. And cohort studies take a large population into consideration, and it follows a specific patient with a specific condition, say for example diabetes mellitus type 1. And it follows that patient and a particular treatment over time and compares them to another group that hasn't been affected by the condition. So this could be a placebo group with no diabetes mellitus. Cohort studies are observational, but they're considered not as reliable as a randomised control trial, since the two groups may differ in ways other than what is wanting to be studied or the variables in the study. Then you've got case control studies, and these are also observational studies where patients who already have a specific condition, the case group, are compared with people who don't have the condition, a control group. And these studies are usually less reliable than randomised controlled trials and cohort studies, because showing a statistical relationship doesn't mean that one factor necessarily caused the other. These studies look back into time, and patient records are usually reviewed. Then you have case reports, and they consist of collections of reports on a treatment of an individual patient or report on a single patient. And they don't use control groups, and they have no statistical validity. Some of the common misconceptions related to evidence-based practice include: evidence-based practice is a cookbook for medicine. It's overly dogmatic, inflexible and too uniform, one size fits all. Not true. Evidence-based practice can be based on any reasonable evidence. Not true. It's meant to be based on current best practice. Misconception number 3, evidence based on basic science and surrogate or alternative outcomes can reliably be used to determine best practices for patient care. Not true again. So, why promote evidence-based practice for nursing? Well, commonly stated, we don't want to waste resources. Healthcare is economically expensive. To reduce the amount of disability and suffering of patients by giving the most current and effective care. Evidence-based practice supports the establishment of specific nursing interventions for the care of their patients. So for example, nursing protocols, which include pressure ulcer prevention, wound care, hand hygiene practices, have changed nursing protocols. This is evidence-based practice. Evidence-based practice in nursing, what else does it do? It facilitates nursing care, defines best practices, enhances nursing efficiency, ensures nursing care advances, employs new knowledge for the staff, and improves patient outcomes and satisfaction. It assesses clinical practice concerns. So therapeutic care is more effective. It advances quality care, and it addresses health issues which are related to the public, especially currently, 2019, 2020. So, in conclusion, evidence-based practice in nursing guarantees care interventions which are based on data from research which ensures that clinical practices are appropriate, safe, and of a high quality. So therefore, we as nurses must develop a culture of inquiry to support and maintain the process of evidence-based practice. So, always demand evidence, best practice evidence, and when you get that evidence, you think critically about it. Thanks everybody. Check out any of the other Dr. Mannys Learnshops on YouTube if you thought this was of any benefit to you. Bye for now.